Thank you, Mr. Chairman. Thank you very much for inviting me for this presentation and the real important topic that we will talk about throughout the day. Actually, my presentation is a little bit overlapping with Dr. Faisal's presentation, but to open a snap into talking into medical management, I have to go through these particular aspects, but you have covered a good number of it. So this is the sequence that we will talk or will present. We'll give a brief background, then we'll talk briefly about the etiology, a little bit of things that I would like to stress on before we go into the real problem, which is postpartum hemorrhage, and how to me, postpartum hemorrhage starts, medical management starts by preventing postpartum hemorrhage, and then we manage the postpartum hemorrhage once it's occurred, because most of cases of postpartum hemorrhage are really preventable. Then we'll talk about the team organization and system organization that may help in preventing and even managing postpartum hemorrhage when it occurs. So we all know that, as Dr. Faisal said, that PPH is a significant contributor to severe maternal mortality and morbidity. The major problem usually in low-income countries rather than in developed countries, but even in developed countries, it's one of the three major causes of maternal mortality throughout all the cases, along with embolism and hypertension. In WHO, it's mentioned that 25% of maternal mortalities across the world are related to postpartum hemorrhage. However, in low-income countries, more than 90% of maternal mortalities are related to postpartum hemorrhage. And even one woman is dying across the world every 4 minutes because of postpartum hemorrhage. It is a real health problem, particularly for women. The more problem is identifying postpartum hemorrhage. The real problem is to identify postpartum hemorrhage, because in most of the cases the diagnosis is late, and that's why whether medical or surgical intervention are usually late. And after losing very valuable time that can save the life of the mother and sometimes the baby. So the definition of postpartum hemorrhage is controversial. There is no definite final definition, because not all women enter labor in the same situation. Some of them will enter labor with medical problem. Some of them will start labor while their hemoglobin is too low, and you cannot compare a patient starting labor with a hemoglobin of 8 with a patient who is starting labor with a hemoglobin of 13 when they both lose 500 or 1000 ml. And that's why in the new classification they have introduced a clinical situation of the patient at the time of bleeding. So blood loss, yes, but together with and the criteria that was mentioned by Dr. Faisal, pulse and respiratory rate and other clinical findings, because these accumulative information are a guide for the physician to start transfusion and to initiate certain action regarding the postpartum hemorrhage, and not only confining the diagnosis with 500 or 1000 or whatever. So the problem is identifying patients at risk and start the management, whether medical or surgical, timely, based on the initial risk that has been identified for these patients. The most important, as Dr. Faisal mentioned, is primary, because usually patients who develop severe morbidity and mortality, they do develop primary postpartum hemorrhage, and the major cause of postpartum hemorrhage, primary postpartum hemorrhage, is usually uterine atony, along with the other reasons of postpartum hemorrhage. Risk factors are not all the same, and that's why when we look into a patient with risk factor for postpartum hemorrhage, we have to keep in mind that there are certain risks that carries more morbidity and more likelihood that this patient will develop postpartum hemorrhage. And this is part of the medical management of postpartum hemorrhage, because identifying the risk and keeping the patient with special preparation, special circumstances, and special attention is really something important to keep everybody alert in identifying that postpartum hemorrhage early. For example, retained placenta carries 3.5 time risk for the patient to develop postpartum hemorrhage compared, for example, with augmentation by oxytocin or induction of labor that carries 1.5 increased risk for developing postpartum hemorrhage. There are so many classifications in identifying risk and in preparation of patients for management of postpartum hemorrhage. One of them is the 40s, where patients has been identified or classified in 3 main categories. The first one, this patient has to be managed in a consultant-based center, and those patients were identified to have a suspected proven placental abruptio or known case of placenta previa, multiple pregnancy or preeclampsia, because the risk of developing postpartum hemorrhage is as high as 13 times compared with normal population delivering patients. The second category, they need really a special attention and discussing the setting of their deliveries, and these are previous history of PPH, ethnicity, obesity, anemia, and the lower risk where that risk that occurs during labor, and those patients carry a risk of 4 times to 2 times of developing postpartum hemorrhage. So looking into these classification and looking into our patients is really important. There are so many types to classify our patients, and even there are instruments or tools to classify our patients during labor into low risk, intermediate risk, and high risk. And while low risk can be attended by, for example, midwives, or take lesser attention from the on-call obstetricians, the high risk needs really a very high attention and preparation. So if we identify those patients and classify them, so we are managing them from the start by cross-matching and preparing and looking into their hemoglobins and sort of things. In a study that was done in our institution, postpartum hemorrhage incidence was about 1.6 per 100,000 women per year. And this is of the very low incidences of postpartum hemorrhage. The risk factors that has been identified in our institution were patient's parity, preeclampsia, previous history of antepartum hemorrhage, the presence of antepartum hemorrhage, multiple pregnancy, and CTG abnormality, and the obstetric interventions that are related to CTG's abnormalities. So as we've said, the problem is to estimate accurately the blood loss. What is happening, and this is not something related purely to obstetric, it's all over. Physicians and even anesthetists and nursing, they tend to underestimate the blood loss, and this underestimation internationally is known to be between 30 to 50% when they visually assess the blood loss. Using objective method like testing the hematocrit before delivery and after delivery, it is something objective, but do we have time during postpartum hemorrhage to wait for hematocrit level? Definitely not. So we can diagnose that retrospectively, but it's not really a help in our initiation of management and introduction of medication, and even sometimes reaching to push the patient into OR for surgical intervention. So the other problem, as I have said, that the patients enter labor with different capacity to cope with blood loss, and this is really something that we have to identify from the beginning. And as we've said, the accurate definition of postpartum hemorrhage is not really concluded. The problem also is that most patients with postpartum hemorrhage that have ended in maternal mortality and morbidity are really preventable. And most of them, they are due to late diagnosis, inappropriate management, or maybe inappropriate resources that led to inappropriate management, and lack of available management system. And therefore, or maybe all of these things together. And therefore, if we arrange a system and if we arrange adequate manpower and resources in areas where patients are delivering, then we start by what is called prevention. So we have to prevent, because most of the cases of maternal mortalities are really preventable. And to start with the prevention, it's very simple. Active management, apart from this system preparation that we will talk about at the end, active management of third stage of labor is really known way of preventing postpartum hemorrhage effectively. And it depends on uterotonic administration of after all birth, gentle contraction and uterine massaging if we suspect that the patient might go into atony or if she is high risk for postpartum hemorrhage. And just that simple process have reduced, for doing that simple process, you need to treat 12 patients to reduce a blood loss of 500, which is the definition of postpartum hemorrhage, the international known one. You need to treat 55 of them to prevent a bleeding of 1,000 ml, and you need to treat 27 to prevent an occurrence of hemoglobin of less than 9. You need to treat 67 to prevent an occurrence of blood transfusion, and you need to treat only 7 to prevent the use of therapeutic uterotonics, the different uterotonics that we are using. So it's something really effective, really simple, and really easy to teach, even for juniors in labor and delivery. The WHO recommendation, I lost here some markers, I don't know why, but the WHO recommendation for prevention of postpartum hemorrhage, it characterizes the steps that needs to be done. It focuses on the use on oxytocin for prevention of postpartum hemorrhage of 10 international units, whether IV or IM. And that oxytocin, if it is not available, or if the patient in an area where no IV access is easy, can be replaced by an oral or rectal introduction of misoprostol. So you can go into the second line of interventions. Controlled cord retraction is really recommended, even during cesarean section, and late cord clamping is really recognized as a reasonable way of, it's here, of managing, preventing postpartum hemorrhage, as well as sustained uterine massaging and checking the tone of the uterus to prevent the occurrence or to avoid delay in the diagnosis of postpartum hemorrhage. So the management, as we've said, starts by early identification of postpartum hemorrhage. There is no way, no ideal way of early identification of postpartum hemorrhage unless we anticipate that postpartum hemorrhage might happen to any delivering patient, especially for those high risk. The ideal way of estimation of postpartum blood loss should be accurate, practical, consistent, readily communicated, and easily incorporated in labor and delivery protocols. But the most common and practical way of testing postpartum or estimation postpartum hemorrhage is visual estimation. The other methods like gravimetric estimation, photometry, hematocrit before and after delivery, and others are not really practical. So if we go to the criteria before and return to the visual estimation of postpartum blood loss, we find that postpartum visual estimation of postpartum blood loss is practical, readily communicated, and easily incorporated, but actually it's not accurate and it's not consistent, because I can estimate 500, you can estimate 300, and she can estimate 700, and we are in the same setup and the same training. That's regardless our training, regardless our background, and regardless our experience, length of experience. We all, if we did not put in mind certain type of education about estimation of blood loss, we will estimate wrongly. So we have done this test in our institution, and we have compared gravimetric with a visual estimation of postpartum blood loss, and even we compared it with pre and post hemoglobin level. And we have reached the conclusion that every healthcare provider that are dealing with patients during labor, starting from nursing, nurse ending by anesthesia consultants, are underestimating. And this underestimation was an average of 30%. So we were underestimating by 30%. We looked into how this can be overcome, and it appears that education for healthcare provider during labor do help in reducing the error in postpartum visual estimation, postpartum blood loss internationally. When we did the effort in educating all healthcare providers that were sharing with us this test, we noticed that, and we did use a simulation for that, for very little blood loss, mild, moderate, and severe excessive blood loss. We noticed the following. Initially, and that's an international, and you can reflect this on all international figures because they are similar. Initially, there was very significant underestimation of postpartum hemorrhage, and that underestimation was higher the more the blood loss is. So the more patient, this patient is in real risk of losing, to be exposed to significant mortality and morbidity, morbidities and mortality, the healthcare providers were estimating the amount. Now, after presenting an educational sessions for the healthcare provider, that underestimation has improved significantly, but yet they continued to underestimate. If we go further and say, why not to give them the patient's condition, the vital signs and pulse and all the situation of the patient, so maybe that will help in improving their performance. Actually, when this happened, there was marginal improvement, but did not improve significantly. So the major thing is to estimate visually, regardless. But so far, there is nothing in the literature that will say that accurate or correct estimation or the effect of education in reducing the error in postpartum visual estimation of blood loss is going to improve on fetal and maternal outcome. Nothing, to my information, has been published, particularly on this. We have unpublished data that have proven that maternal outcome, the hemoglobin difference before and after, has improved significantly, and the fetal outcome first minute Apgar score has improved significantly when we implement education for visual estimation of postpartum hemorrhage and implemented properly during labor room setup. So starting from prevention and early identification of patients with postpartum hemorrhage, we go into medical management. Actually, the first thing is to early detect, and then, as Dr. Faisal Safi had mentioned, multidisciplinary approach that aims to maintain the patient hemodynamically stable and identify and treating the cause. If the cause is not surgical, then the cause should be started by treating it medical, and we usually escalate the method of management of postpartum hemorrhage gradually until we reach the final resource or taking the patient to OR for surgical intervention or even hysterectomy. But to do this in an organized way and without panicking, we need availability of comprehensive plan for the management of obstetric hemorrhage in the institute where the patient is delivering, and provider should be familiar with that algorithm. So it's not enough that the institute will have it. The provider should be familiar with that, and a proper education or regular education should be provided for the health care providers in labor and delivery about the presence of this algorithm, and that one should be based on the resources that are available in the institute or the hospital where the patient is delivering. So what fits with certain institute, not necessary to fit sequence-wise and the availability of medication. The first resource is usually uterotonic because most of cases of primary postpartum hemorrhage are related to uterine atony, 70 to 80% of them. And as we've said, or Dr. Faisal was also mentioned, we have to empty the bladder, massage the uterus, give uterotonic, and usually we start with oxytocin. But we go into the second line uterotonics gradually, and there is no literature that proves that one of them is priority to the other. So the sequence of the next uterotonic, if oxytocin did not work, it doesn't matter. It depends on your training availability and the facility that you are dealing with. So you can go with methyl ergometrine, you can go with prostaglandin F2 alpha, misoprostol, and the sequence of these is not necessary to be equal across. Tranexamic acid is also out of the medication that can be used to manage medically postpartum hemorrhage. It's an antifibrinolytic agent that has a modest effect on the prophylaxis and treatment of PPH, but literature has shown that use of tranexamic acid is better than placebo in reducing maternal mortality resulting from PPH. Risk of thrombosis resulting from tranexamic acid is not considered during the use for postpartum hemorrhage, and they did not detect that it has increased the risk of thrombosis. So it can be used, but it should be used within the first 3 hours of postpartum hemorrhage. So if you are planning to use it, use it. Carbitocin, it's an agent, it's an agonist at peripheral oxytocin receptors, mainly used for prevention of postpartum hemorrhage in cesarean section cases. There is no strong data that proves that it is a good medication to be used for management of postpartum hemorrhage. Tamponade, regardless the method of tamponade, it can be used meanwhile you are preparing either for medical or surgical intervention of postpartum hemorrhage, and I will leave this to the surgical side of the management. But non-pneumatic anti-shock garments are really an instrument that can, it's something that the patient will wear in her lower half. It will give a pressure in a way that it will reduce or reflect the blood that is remaining in the patient's circulation into its vital organs, mainly the brain, and that will delay the occurrence of the shock and will give further time for the providers to start managing the patient. So it restores the woman consciousness, pulse and blood pressure, and decrease bleeding from the part compressed under it. And actually combined analysis of 1,442 negative outcomes were significantly reduced. Combined analysis of 1,442 patients, it was found that negative outcomes were significantly reduced, and negative outcomes meant by severe morbidity and mortality. So maternal mortality decreased by about 44%, and severe morbidity was reduced by about 80%. Emergency hysterectomy was reduced by about 56%, and number needed to treat to prevent either mortality or severe morbidity was 18. So it's an instrument, easy to be used. I don't think it's costly, and it's something that can give time before the patient will go into shock, will give time to prepare the patient, especially in areas with low resources, or if the patient requires transfer. There is a full lecture on uterine artery embolization, transfusion, and massive obstetric hemorrhage. Actually, the main thing in postpartum hemorrhage is to keep the patient with adequate circulation and oxygen carrying capacity. So there will be no loss of oxygen or reduction of oxygen into her vital organs, or low circulation into vital organ, and we end by multiple organic failure even if we survive with the uterus or whatever. So transfusion, usually in massive postpartum hemorrhage, we go into massive obstetric hemorrhage, and usually our anesthetists are the key people in doing that. Actually, a massive obstetric hemorrhage should be part of comprehensive management plan. So when we put a plan on how to manage postpartum hemorrhage, how to organize the massive transfusion should be there. And we have to be very careful to low fibrinogen that should be anticipated in a setting, especially with a placental abruptio, amniotic fluid embolism, and early use of cryoprecipitate factor. Other methods like cell salvages, usually this method, you need to know that you are going into a case of postpartum hemorrhage, because some of our postpartum hemorrhage are unpredictable, so this is rarely used in obstetrics. Prothrombin complex concentration and fibrinogen concentration, data regarding the use of them in the setting of PPH and disseminated intravascular coagulation are limited. Recombinant factor 7, we rarely use it in postpartum hemorrhage, but sometimes we opt for that. Usually the role of recombinant factor 7 in primary PPH is controversial. It significantly improved hemostasis in PPH, but also may result in life-threatening thrombosis in 2 to 9% of the cases. So it has to be used with caution, and usually in our institution we consult with hematologists. So hematologists should be with us online when we decide to use recombinant factor 7 for cases of postpartum hemorrhage. Actually, the most important thing is to have a system. To have a system where you organize your work and you have a algorithm of how to do and whom to call and what to call at what time. So health facilities delivering maternity services should adopt a formal protocol for the prevention and treatment of postpartum hemorrhage in the presence of multidisciplinary team that is well trained for the management of postpartum hemorrhage. Confidential inquiries have highlighted that lack of communication and teamwork are leading cause of maternal mortality even in developed countries. So in developed countries where all the resources are there, the reason usually is lack of communication and teamwork if maternal mortality occurred because of postpartum hemorrhage. Not only this, skilled birth attendant at delivery and health expenditure are key variables that predict maternal mortality at a national level. So the presence of facility, team, and skills are really important to maintain a patient's life when she developed postpartum hemorrhage. So we should have a system. What happens in most of the institutions all over the world, on-call team, they are faced with postpartum hemorrhage, they react to postpartum hemorrhage, and then, based on what they are facing, they will start calling. I need a urologist, I need a hematologist, call blood bank, we have massive transfusion and sort of things. And it's the same team that is managing all the patients will be managing that catastrophic case. This is time consuming and may contribute to patients' morbidity and mortality. So what is the solution? In medicine, and the medical side of practice, they have created what is called medical emergency team. So medical emergency team is a system that was introduced to treat patients at risk, suffering from adverse hospital event. The survival of those patients are usually determined, whether cardiac attack or whatever other reason, is usually determined by several factors, especially early recognition and prompt appropriate treatment. So if this happens, that will decrease the mortality and morbidity of those patients. And delayed activation of medical emergency team for those medical patients is usually associated with increased risk of death or severe morbidities. Reflecting this on obstetrics. So, if we say that medical emergency team, you cannot have all the specialties are there, but rapid response team model consists of lower level of categories who can ramp up the response to include additional responses if needed. So we have now two types of emergency teams, medical emergency team and rapid response team. Medical emergency team, everybody has to come at once and do the business, while rapid response team, somebody will come out of the team, identify the situation and start calling for help. Depends on the situation that's ongoing. So if we think about rapid response team at a nursing level and medical emergency team at physician level for cases of postpartum hemorrhage in the institution, that may help the institution itself and maybe even help regionally the institutions that are beside. Because if we think practically, for example, in National Guard, we have all specialties. We can call everybody at any time and everybody's on call. Everybody will respond. But some nearby hospitals that are few kilometers from our hospital, they don't have this luxury. They don't have as good blood banks. They don't have as good availability of all specialties and maybe the skills to manage. So if we think widely in doing that and creating that team, which I have been proven in the literature by several authors that has been introduced in their setups and even in developed countries have resulted in reducing maternal mortality and morbidities that are resulting from postpartum hemorrhage. So if we think that we define a policy concerning the function of that team, establish that team to serve institution and region even, and utilize the various experiences that has been published elsewhere in creating that team, we may help in reducing maternal mortalities and morbidities that are occurring because of lack of resources or maybe lack of experiences at the time of its occurrence. The applicability of this service will be provided upon application and applicable to either emergency or even elective cases. So in that case, in any institution, if they do have placenta accreta or percreta, but they don't have the skills to do it, they can still keep the patient with them and that team can be activated to give them assistance at that time. Of course, there should be an activation criteria that is fixed so the team will be known, and a sequence of events that should happen in case of emergency activation or even in elective activation, so patients will be identified, treated, and managed by the best skilled people that are prepared to manage these cases, and the lab is ready, everybody's ready, with adequate education and privileging. That can extend widely, can extend across the regions, and even you can have a map to the city or to the area where you can map every few hospitals that can share that team together. So in conclusion, postpartum hemorrhage is a major health problem contributing to maternal mortality and morbidity, and most of the cases are preventable. With active management of third stage, we are going to reduce significant number of them, and with the implementation of system that can work on preventing and managing postpartum hemorrhage, also we can do further prevention of catastrophic obstetric hemorrhage that may result in patient death. Thank you.